Good morning. I have to apologize for the late start. It's some problem with traffic, as some of you may have noticed already. My name is Mohammad Surfraz. I'm the CPD lead at the University of Hertfordshire. And we've put this conference together because we think it's quite a niche area, really. Very specialized and sometimes go unrecognized for the amount of work that goes in. Quite often, when somebody with a learning disability offend, we are faced with some questions whether we should report it or we should keep quiet about it. And if you talk to people on the shop floor who are working with offenders, a lot of them put up with a lot of unnecessary burden because they are afraid or they are not so sure whether they should report it, or because the person has a learning disability. With the advent of Winterbourne and post-Winterbourne, I think there's going to be a lot of changes in terms of service delivery, and hence we thought this conference would be ideal at this time. And hopefully we can address some of the issues facing offenders and professionals on the shop floor. When someone with a learning disability commit an act, whether that act is an offense or it's a criminal act, when we do decide to report it, they go through this journey, And that journey very much depends on whether the person's learning disability has been recognized. If it has been recognized, quite often the outcome is very different. And if it hasn't been recognized, the outcome can be very lengthy. The person may end up going through that journey into custody before they get disposed or diverted into hospital. So there is a lot of issues there. The police, interviewing, investigation, the presence of an appropriate adult, the rights, entitlements of the person with disabilities. And when it goes to crime prosecution service, issues come up around fitness to plead, or whether we should prosecute. When it goes to court, how is a person represented in court? And then the outcome of the court, whether the learning disability has been recognized in court, the disposal could vary from probation to custody and hospital orders. There is a lot of issues there, a lot of good practice happening, around the country, and hopefully we've got a packed agenda for you that will address some of that issues. I'm not going to stay too long. We're going to co-chair the conference today, myself and Paul Maloret. So I would like to introduce you my academic lead at the University of Hertford Learning Disability Studies, Paul.
Good morning, everybody. Okay, we've got 5 keynote speeches for you today and 12 workshops. I need to let you know early doors that we are down to 11 workshops, and if your choice C on the first round of presentations and workshops this morning with Gary Doherty, he turned up at the wrong venue this morning, unfortunately. So if you were on that and your name would be on the list outside, you need to move to another workshop, so sorry about that. We have been hit by traffic problems quite dramatically this morning. There's lots of people still stuck on the M25 and local traffic problems up at the main roundabout, so people will be kind of drifting in and out. Okay, so if we could just have a quick look at the agenda and quickly review the agenda, that would be good. For me, there's 2 main themes that are coming out of the agenda today. One of people with learning disabilities who have been diverted through the criminal justice system, as Mohammed's already talking about, and find themselves in prison. And collectively, we've tried to produce a group of workshops and presentations for that particular group of people in looking at people, how we use appropriate adults, for example, the work that's been undertaken by the Department of Health to review offenders and how we divert offenders away from prison. The work that the Dan Shell Group are here today to present some excellent work actually about identifying and supporting people with learning disabilities, a real problem about how we identify people in our prison systems who have a learning disability. And a very interesting study that we're going to hear about from the Tizard Centre about what happens after offenders come out of prison and the statistics around reoffending. The other main group, obviously, really, is how those groups of people that have been diverted to healthcare settings and obtain treatment orders via the courts. And for that, we have programs around sex offenders and treatment of sex offenders. Positive behavioural support is explicit in many of our presentations today. Actually, we have very directive presentations around PBS, but I think there's lots of elements of PBS that come through many of our presentations. Risk and service user involvement, the use of internet, reducing restrictive practices. We've got presentations on suicide and prevention of suicide, and the student experience and how we prepare those students for forensic settings, which should be really interesting, I think. Okay. Other things I need to tell you about very quickly is car parking. If you've got a ticket, you can swap your car parking ticket at main section. They give you a free ticket to come out, which is handy if you can make sure that happens. Okay, we're going to move swiftly on to our keynote speaker this morning. The Bradley Report is something that's very familiar to all of us, something that's very explicit within our teaching, our curriculum of learning disability nursing at the University of Hertfordshire. And who better really to present the report and its recommendations and what's happened since its publication in 2009 than the author himself, Lord Bradley. Let's come up, thank you.
Thank you very much indeed for the introduction and for inviting me to make a short presentation at the beginning of what clearly is an excellent conference around the issue of mental health, learning disabilities in particular, and the criminal justice system. Can I first of all apologise right from the start? I have to leave at the first coffee break, but to say, if anyone wants to discuss any of the issues that come out of today or with your work or the general direction of travel of the services that I'm trying to help develop, please contact me either through the House of Lords or through the University of Manchester or any other way you want to contact me, and I'll be very pleased to talk to you further about your work, because you're the experts, I'm not. I'm a mere humble politician who is trying to help set the agenda and policy direction in one discrete area of work. And that's why I was asked by the then Labour government back in 2007 to look at why so many people with mental health, learning disabilities and complex needs end up in prison. And it was very simple answer, as you all know, because no one actually knows they've got mental health or learning disabilities or wider complex needs, alcohol, drugs, until they end up in prison. So the report was about trying to find out how the system was working that led to that outcome, what we could then do to change the system, and then set upon a journey to try and implement those changes. So, as I said, I was commissioned in 2007 and reported in April 2009 to the then Labour government, who accepted the 82 recommendations I made at that point for change. Very, very briefly, because time is very limited, and I will try and allow a little bit of time at the end of my short session for questions, but I say do follow up later. All of this will be very familiar to you. What was happening, as I've said, was that the opportunity to identify and take decisions about the needs of the individual was happening too late in the system, and at that time, too late meant they'd end up in prison. There was lack of adequate assessment and identify identification of the problems early in the stage. There weren't tools to actually undertake that assessment that were common across the health and criminal justice system for that identification. There was poor continuity of care. If someone was recognised with a problem, no one took responsibility for what happened next. And there was an inevitable pathway along the criminal justice system through the courts before any recognition of a problem. Organisations didn't share information. They'd maybe collect information about learning disabilities, but they wouldn't share it between organisations. So at each stage or each contact with an organisation, the system started again to identify and make decisions. There were a lack of joined-up services, particularly where there was dual diagnosis. So there may be a presenting problem, which may be alcohol, it may be drugs, it may be mental health, but there wasn't a joined-up way of looking at the needs of the individual at that point. Because organisations at a local level, regional level and national level were working in their own organisational silos, and that meant there were barriers to sharing information, barriers to continuity of care, barriers to people working together in the interest of the individual rather than the interest of the organisation. There was lack of understanding by the courts of what alternatives there were to custody, whether that be into the prison setting or into a health setting. There was no real understanding of the opportunities for community-based sentencing or support to enable someone to be cared for in the community as opposed to in a secure setting. There was a woeful lack of training throughout the criminal justice and the health and social care system on mental health, learning disabilities and other complex needs. That individuals were not recognising the problems because they weren't trained to understand or recognise those problems. And crucially, there was little experience and understanding of what an individual who was passed through the criminal justice system, what the problems were that they experienced along the criminal justice system, and that their input into the outcomes that should flow from it. So, I made 82 recommendations, which clearly this is broad brush. All of this is broad brush. We needed to intervene earlier in the system. We needed to have common assessment tools across organisations, but with particular, within those common assessment tools that recognise learning disabilities separate from mental health, separate from other issues. So it was gathering information, but not forgetting the particular needs of the individual around learning disabilities. We needed to have much better data collection and sharing of that information through enhanced investment in technology. As you will all know, too many organisations have their own discrete computer systems, and it's very hard to share that between organisations. So the health service wasn't sharing information with the police weren't sharing it with the courts weren't sharing it with the prison service, they weren't sharing it with the Crown Prosecution Service, they weren't sharing it back into community services. So that information was collected, but it was collected over and over again by different organisations because they couldn't automatically access that information between those organisations. I remember being in Middlesex Crown Court, seeing a whole room of individuals transposing computer printout onto manual records to hand into the court. What a waste of time, what a waste of effort. We needed to look at the way in which there could be improved training, but improved training across organisations, not within organisations, because there was a lack of understanding from the different organisational cultural perspectives about how they dealt with the same person. So coming together, to train together, to bring all organisations together, to train around the needs of the individual was a much better use of resources and had a much better outcome. For those that did end up in prison, we needed to have further investment in prison healthcare. And to achieve this, what I recommended, crucially, was the establishment of what I called then criminal justice mental health teams, which were a multi-agency team working at the first point of contact with the criminal justice system, which is normally the police station, to ensure that even at that stage, which is too late, but even at that point, there is an identification and an assessment of the needs of the individual to support the police in taking the right decision. Now, so the question that's posed to begin, should we report? Well, should we report is about who comes into contact with that individual, what the team of people who are making the assessment, what their skills and opportunities are, and then for a decision to be taken, whether they need to be charged and or whether they can be diverted back into the community, because often the offence may have been committed for something as simple as them not taking their medication and therefore getting into a crisis, getting into trouble and getting taken to the police station. So we needed a team that was then responsible for the continuity of care. So if the decision to charge was taken, then the team would then follow the person through, and if it was through into the criminal justice system, they would gather the information and have that information available at the first court appearance, ensuring that appropriate adults were available. They'd arrange that, they will arrange that, and that the courts are aware at that first appearance of the needs of that individual, that vulnerable person's needs at that point of contact with the criminal justice system. And the opportunity for that team to help the custody and the charging sergeant in the police station to make a sensible decision about what that next step should be. Invariably, depending on the nature of the offence and the nature of the problems that the individual has, diverting them back into community services. But if they go to the courts having the information to allow them to take a decision there and then about whether maybe a community sentence is the appropriate disposal, for example, a community sentence with a mental health treatment order attached to it, as opposed to what was happening, and still happens to an extent, is that the person at that first court appearance is remanded into custody, remanded for several weeks whilst a psychiatric report is written, and often when they then finally return to the court, the sentence, because the nature of the offence, is less than the time they'd actually spent on remand. And whilst they're on remand, nothing is done to help or support that individual. It's just a wasted period of time at huge cost. They go back to court, they may be sentenced, less time they spent on remand, so they go back out of the court, back into the community, and nothing has happened to support and help them. And the more likelihood is, and particularly the women who find themselves in that situation, in that period, they have broken their links with their family because they're on remand in a prison away from home, broken the links with the children, so there's social services then get involved in the needs of the children. They may have lost their job, they may have lost their housing, and all you do is actually exacerbate the problem and cause more problems because nothing has happened in that period. If the courts know at that first appearance all these issues, then more sensible decisions can be taken. So, we need to move on quickly. So, what then happened was there was a change of government, and in 2010 a coalition government came in, and depending on your point of view, there was a little delay because they introduced the Health and Social Care Act, which threw all the organisations that we were dealing with before up in the air, and we had to start again. But crucially, the coalition government accepted again all the recommendations for change, and so once the Health and Social Care Act had settled down, we were able to continue the process of implementing change. And crucially, what was agreed again, that there'll be a national rollout of liaison diversion services, which the genesis is my criminal justice mental health teams. And critically within that, there was a recognition that places of safety for people who are sectioned under 135, 136 were totally inadequate around the country. There'd been some investment in places of safety, but there had to be a recognition that liaison diversion doesn't mean anything if there aren't appropriate services to divert people to. One of those diversions is into places of safety, and we need to develop far better facilities around the country with proper protocols between the police and the health service on places of safety. An added element that has been brought in is street triage. This was a slightly separate initiative through the Home Office, but is now linked to liaison diversion, which is taking a step back from the police station into the community before people get into trouble. And street triage, as I'm sure you know, is where the police and the health service work together on the streets, often in a dedicated vehicle, and identifying, recognizing people who may have a mental health or learning disability, who may be about to get into trouble, to try and intervene at that earlier point. And in these vehicles now, or sometimes they're organised out of the police custody suites remotely, the health service, so you'll have a psychiatric nurse or a learning disability nurse working alongside the police officer. They both have their information about that individual available to them in their vehicle, and whilst it is bizarre to go out with them and see a nurse with her laptop and the police officers with his laptop, at least they're sitting in the same vehicle, talking to each other, sharing information and making a decision about what the next step should be, to avoid them being transferred to the police station and into police cells, which was the norm as the place where these assessments took place. What we've managed to achieve over the years is now, by July of this year, there will be a complete ban on the use of police cells for children, and we're moving towards a similar ban for adults. But with street triage, you can dramatically reduce the use of police cells for assessment. In the West Midlands, the year before last, they used police cells 4,000 times. Last year, they used them less than 6 times, because they now have an effective process in place to identify, assess, and not use the police station as the first port of call. So we set about, through project money, through the NHS, to commission services with proper strategic overview at a local level. And we now have services available to every police custody suite in the country for 53% of the country. And the model that's being developed is an all-age, 24/7 service, so that within that you can have particular the needs of young people and women recognised, but it is for all ages and all groups to make sure that no one is limited in the use of liaison services. A lot of work has gone on in training of the magistrates to ensure they understand what the opportunities are for community sentencing as opposed to transferring people into secure settings. And there's been some excellent work undertaken in courts around the country where the magistrates, the probation service, the health service work together. There's a scheme in Milton Keynes where they now make those assessments prior to the court. They recommend mental health treatment order or a menu, because again, community sentences shouldn't be just focused on one aspect of the person's complex needs. you know, if they've got a drug problem or an alcohol problem, they've also got a mental health problem, or they may have a learning disability. You don't want to just, on the community centre, tackle one strand of that, because that's a recipe for failure in other parts. So you need to put the menu together, and training of magistrates who are very receptive to it. Every magistrates association now has a mental health and learning disability champion who ensures that training is undertaken within their areas. But in the Milton Keynes pilot scheme, in the 12 months up to the end of last calendar year, they'd moved from using psychiatric reports, as I described before, with huge delays in the court system and costs and people's family breakdown because they've been on remand. They now use no psychiatric reports at all. They rely on the information that's gathered by the mental health liaison team, and they rely on it because they have confidence, they work together, and they're much more likely now to use a mental health treatment order. And we've got to have that as a common practice across the country. I say training is crucial within this. Local leadership is essential in this. The stage we're at is that we now have a business case going to the Treasury. It's in with the Treasury with a decision this month to mainstream all these services. So moving from a position of it being project money, which is time limited, to being part of base budget for commissioners across the country, with the intention, if that is approved, and I hope it will be, we can move to 100% rollout of the services by 2017-18. So then every part of the country will have access to the teams of people who will be responsible, and within those teams there'll be psychiatric nurses and there'll be learning disability nurses to recognise those particular needs of those individuals, working with the drug workers within that setting and others, having key links back into the community and back into the secure accommodation so that information is shared, people understand the needs of the individuals, and we get a more effective, comprehensive service to try and stop the flow of people who end up in prison or don't get into secure health services quickly enough. Because one of the problems we have at the moment is that there is final recognition of those mental health needs in the prison setting. But having had that recognition and that agreement that they have a mental health problem, getting them then transferred into an NHS secure takes weeks and months. To the detriment of that individual. We have to recognise that before they get into the prison setting and make the appropriate disposal in that way. What we did after 5 years was take stock of where we're up to. And the Commission, through the Centre of Mental Health, we did a 5 years on review, which made a further 9 recommendations, which were particularly around the use of appropriate adults. And we've got the Home Office to agree a working group, which I sit on, to say how defendants have an appropriate adult and have support within the court as to ensure that their needs are recognised. And at the moment, it's not statutory to have an appropriate adult, but we need to move that to that position. And we need to embed all the different strands of the work through street triage, through early identification in the police station, through to the courts and onward in a more effective and efficient way with proper information sharing. We're doing a lot of work particularly on the number of women in prison at the moment. Again, I serve on the government's advisory board for female offenders, because I say one of the biggest problems is for women who normally their offence is a very low-level offence. It's normally shoplifting or related. The sentence is normally 2 or 3 months. It is It is ridiculous that the women should serve that in prison with all the consequences that I've described. But there are currently only around 4,000 women in prison. And there used to be 4,000-ish young people in prison. Through early intervention with young people, we've reduced that population down to 1,000. I believe the target is to achieve the same with women. And one way in which we can do that is the more effective use of women's centres around the country, which is an opportunity to divert the woman from the courts to a women's centre where they're supported in their community centre. Community centres. The women's centres are based close to people's homes, so they don't break that link, and they are supported through the centres. But more importantly, as with all these groups, is supporting them when they're back in the community, supporting them into appropriate housing, supporting them back into proper employment, supporting with their family needs. Unless that support is available, unless we enhance community provision, and these are easy words, but you know the pressures on budgets don't naturally lead to the outcomes that you're looking for. We need to recognise that early intervention and proper continuity of care and support in the community ultimately saves huge amount of money. What is the point of having a woman in prison costing £40,000 a year rather than actually investing that money in alternative services in the community? Answering the question about should you report, I think yes, you should. I think you have to recognise that someone has committed an offence. But what the important thing is then what do you do about that, and what the ultimate outcomes for that individual are if the proper support services are put in place. And I think there's a huge opportunity, if we get the money through the Treasury, to develop the comprehensive services, which I've only scratched the surface on this morning, to actually deliver better services for people with learning disabilities, with mental health and wider complex needs. So I'll stop there, but I'd be very happy to take questions in the last 5 minutes. Thank you. Yeah. No, they're dedicated staff to street triage. They're part of the community support, but they're police officers. In the best examples, they have their own dedicated vehicle with all the technology in, and they're out on the streets. We've got them in Leicester, we've got them in Birmingham, we've got them in Middlesbrough, we've got them in Manchester, around the country. And they're most effective in those dense urban areas where there's a lot of potential difficulties for people. But crucially, they're working alongside a health worker, a psychiatric nurse, and they operate in different models. Some operate 24/7, some, because of resources, have a more limited night time. But the crucial thing is the police custody suite are in contact with them, so they know they pick someone up. They talk about what should be the next step. If they're section under 135, 166, there's a protocol arranged with the Mental Health Trust, with the ambulance service, to take them to 136. It saves police time because with those protocols, the police don't have to sit around for hours waiting for a response to their understanding of the problem. And those that are they're assessed in Birmingham, for example, they have a crisis unit which is attached to the place of safety, and they take everyone there. They don't take them to the police station at all now, and they do an assessment. They're very proud that they complete it within 4 hours, and then they will determine, with the cooperation, the police are there as well, whether they need to be taken to the police station to be charged. In Birmingham, at the police station, liaison diversion team are there waiting to pick them up if they are taken to the police station, to support the assessment, information gathering, ready for the court. I mean, I was told at the start of all this, you can't information share because of confidentiality. The health service can't talk to the police can't speak to the health service, and the courts have to be independent as well. Well, there was a scheme set up in Liverpool where they built a community court. It was in a disused primary school. And they built a courtroom in one of the disused classrooms, and next door they had an open plan office for all the relevant staff from the health service, from probation, from Crown Prosecution Service, from the housing department, and they all sat in this room and they prepared the cases in the morning, ready to go immediately into the court that afternoon, so there was an instant understanding as comprehensive as could be made at that point. And I sat in this open plan office and watched people shouting across the room about, what do you know about Fred? Who's got any information? And because they're in the same room, and because they're all working to ensure the best possible information on that individual was available to the magistrates, somehow confidentiality was being broken down. It was being broken down for the right reasons, because they were actually sharing it in the interests of the individual, not using confidentiality and data protection as a barrier to actually make the most successful next step. And it worked perfectly until resources were pulled out and it was closed down. So that's another story. Yeah.
We're going through a time of magnificent change in those new services. Surfraz was one of our reports due in 3 weeks' time. People want to pause here provisions before Christmas. And probably where there's a 5-year closure program, especially states with the hospitals, which has been 1% in the next 5 years. I think a lot of people I speak to working in the field are concerned that if you're closing hospital beds, the only alternatives will be criminal justice system.
Yeah. Yeah, I mean, from what we were talking about this earlier, one of the issues is having that alternative provision in place in advance of the closure. An alternative provision that actually is in the interest of the individual, rather than trying to squeeze people into another institutional setting. But part of the problem is, with the closure of those beds, people in crisis, access to those beds is being limited as well. And with all NHS change, you need to have the alternative in place before you close the current provision. However poor it may be, there's no point in moving people out and then not having a robust package of care in place to support them. You go back, I'm very old, to the closure of the old asylums, and they closed them, but the community provision was non-existent. So you had lots of people in the community who were not being cared for and not having the support they needed. So we have to be very clear. The outcome of Winterbourne was to say there has to be proper and tailored support for the individuals in the community, and we shouldn't be closing beds preemptive of that. And I'm in my modest way on the case on that to ensure it happens. I'm very involved in the Greater Manchester devolution, the integration of health and social care, and to reconfigure mental health learning disabilities under that devolution package. And what has become clear, one, how many of those districts were using out-of-district services rather than catering for the needs of individuals within their own communities at huge cost, massive cost compared to actually tailoring local services. And we can do better, but it has to be done with investment up front to ensure that's in place to make the savings, because as you rightly say, the consequence if we don't do that is more people in the queue for the criminal justice system. And what I've said to government is I can't change today the 85,000 people who are in prison. 20 years ago, it was 40,000 people in prison. We've doubled it in 20 years, which is a scandal. At huge cost, 40,000 quid a head per year. But what you can do by intervening early, particularly with children, I mean, it's an absolute scandal that children, that I caricature it, they're in the classroom, they may have a learning disability not recognised, so they end up at the back of the class, then they end up out of the class, then they end up in the park, then they end up in trouble, and it's only at that point, maybe through the community support officer, recognising it, that anything's done. So what has happened on that little pathway in the school, and what we're setting up now in every school is a training for mental health, learning disability awareness, not specialists. I'm not expecting teachers to be specialists in these services. What I'm saying is they're passporters. They need to do the recognition and pass them to appropriate, say, CAM services. Now, you'll immediately shout, what CAM services? And I would agree with you. There is a recognition of the inadequacy of CAM services. I'm going all over the place here. I've only got a couple of minutes left. The government have committed £1.5 billion to improve CAMs and adolescent and related services. But when you break it down, that's over 5 years. There are 200 CCGs commissioning these services. Doesn't add up to a lot of money. But it's a step in the right direction. And we have to use the opportunity, as I was again saying earlier, the public recognition of mental health related issues and the political will for change, I don't think has ever been higher. Maybe for a pretty low base, but I don't think it's ever been higher. We have to seize this opportunity to actually do better on a whole range of issues.
I come from Middlesbrough, so
Yeah.
on the triage.
Yeah, I'm going up there shortly.
We're finding that funding, particularly on training, so we're employing quite a number of mental health nurses, maybe one learning disability nurse like in a liaison service or within offender services. And what you tend to find is the culture is still quite predominant towards the mental health side, and so you get the learning disability nurse absolutely pack out because people are referring, and yet there's not a whole heap of money towards training and equipping others to do the screening. So I had a student come to me who's a nurse talking about how they do their mental health assessment and now we have to do this learning disability. And she literally said, I'm not a clue. I've not worked with people before. So where's the training kind of funding mentality coming from?
Yeah. On the training, I'm a trustee of the Prison Reform Trust, and we have a strand of work specifically being developed on training for learning disabilities, and that program is slowly being rolled out to organisations for exactly the sort of specific training you're talking about. What is crucial though, because which budget goes first? Often the training budget. Which budget shouldn't go first is the training budget, because that's where you actually can make a difference and actually look at services through that training eye to develop them in a more effective way. But I also think that because budgets within organisations often cut, pooling those budgets across the health, social care, criminal justice system is the way, one, to get better use of that money because you're pooling that resource, but more importantly, getting all those organisations in the same room, talking about the same person, breaks down so many barriers in terms of understanding these individuals from the different cultural organisation perspectives and getting people to talk together in a room. I went to, where was it? It was a West London court, and I was meeting the judiciary. But before I went to meet the presiding judge, I went down into the cells, and there were two mental health workers in the cells trying to gather information to present to court. So when I met the presiding judge, I said, I'm just thinking in the cells, how do you work with the mental health people then? And she said, Well, I've heard of them, but I've never actually met them. So I was having lunch there, so I invited the mental health nurses in for lunch, and they started talking together. And just in an hour, the breakdown of barrier between the judiciary over there and what was happening in the cells was just remarkable. And it then got an enhanced service in the West London Court. So I think bringing people together, rather like the Liverpool work that's done in that court. And you know, I went street triage was first being developed. I went to a training session in the Peace Training Centre in Coventry, and I walked in, and the nurses were in one corner in their nurses' uniform, the police were in the other corner, and they sort of looked warily across the room at each other. I went back 12 months later, and I walked into the same room. I didn't know who the nurses were, because they'd broken down all those cultural barriers, and they realised that actually they could help each other do a better job in the interest of the individual. So I think more work needs to be done around that. I have no doubt about that. Programmes are being developed through the Prison Reform Trust and the Centre for Mental Health, which I should declare I'm trustee of that as well, to actually identify what you say. But I'm coming up to Middlesbrough before Easter, and we can talk further then. Okay. Well, thank you for inviting me, and have a good day.